And welcome to today's Journal Club. I'd like to thank ESGO and IJGCS, as always, for their support in our Journal Club. I'm Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Really excited about this topic, but before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. So participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so that we can hear the presentations. And if you're having any difficulties or questions, please send a message in the chat and our technical team will be happy to assist. We also always want to encourage questions. So we're really excited not just to hear the questions from our fellows in the International Journal, but also questions from everyone that joins the Journal Club. So as I mentioned, very, very excited. This month's lead article is the ESGO INCIP guidelines for the management of patients with gynecological cancers during pregnancy. Dr. Michael Haleska is joining us from Charles University, Third Medical Faculty, Department of Obstetrics and Gynecology in Prague in the Czech Republic. So we're really very, very pleased to welcome you, Michael, to the Journal Club. Excited to have this discussion. Thank you for being with us today and sharing some of the deeper insights into this article. So again, thanks everybody for joining, and welcome Michael Halaska. And again, we'll proceed with a brief presentation by Professor Halaska, and then after that, we will begin with our questions. So thank you.
Thanks a lot, Professor Pedro Ramirez, and thanks to the journal actually for having the chance to place our paper in this journal, because we feel that it has a high impact on the oncogynecological community, so we are happy. So let me share my screen. Okay. Oh, it's running now. And actually, guidelines regarding cancer or gynecological cancers during pregnancy are not new. These guidelines are already the fourth one in a row. We publish them every 5 years. But this time it was the first time when we used the methodology of ESGO. INCIP is an international group of specialists who are interested in cancer in pregnancy, and it has been here since 2006. And we have been working on this topic for a long time and quite successfully, because we produce many international guidelines. And regarding publications, I feel that there are around 35 or 40 highly impacted publications. So we feel that we like this topic, and we are happy to present the issue. Now, just shortly about the guideline development process, we were two chairs together with Frederic Amand, who is actually the founder of this INCIP group. And first, we identified experts in this field. They were international, mainly from Europe, but actually we have one also from the United States. That's Alice Cardoni, who was one of the, I would say, like a grandfather of this topic, or grandmother. And we have also available the methodologist from ESGO, that was Francois Planchard. First, we started with a literature search. We have limited most of the journals of the papers from 2004 till 2024. And we have grouped these specialists and experts into smaller groups in order to give them topics that they should look at, and also to cover topics such as epidemiology, diagnostics, treatment, follow-up, and also patient perspectives and psychology. After we have created the first draft, we have sent the guidelines to reviewers. There were actually 102 clinicians from different fields, as you can see in the bottom. And they actually gave us a lot of remarks to our guidelines, which we actually had to solve. So we had 2 days meeting in 11, where we discussed all these remarks. It was quite interesting to see that the majority of the topics and the fields, there was a high concordance with the guidelines. There were no major discrepancies. So almost all the topics were agreed by more than 90% of the reviewers, which was really good. So we didn't have that much work, but still we had to incorporate remarks from 102 clinicians. It was quite a lot. So sometimes it was difficult. I will just go very shortly through several topics. Give me like 10 minutes and then we can open the discussion, and let's go to the questions. Regarding the incidence and prognosis, we have more and more data from different countries regarding the incidence of cancer in pregnancy, which generally is quite low and is a rare disease, we would say. But it is really interesting and hot topic because it covers two patients, actually. It covers the woman with oncological disease, but also the newborn. Very important message from all or almost all epidemiological data is that pregnancy itself is not worsening the prognosis of gynecological cancers. Actually, we can also include that it's not worsening breast cancer, which sometimes is not included in gynecological cancers. And this is actually pivotal finding and very important one, because then from this point, we can start to focus more on pregnancy preserving management in these patients. Regarding the imaging, it is quite clear that ultrasonography is one of the mostly recommended imaging methods, because it causes no harm to the patient, and it is accompanied, of course, with magnetic resonance imaging, which is also quite commonly used. One of the latest findings is that we should not use actually gadolinium contrast agents, only in really special circumstances where we need it, and it's quite rare when we discuss the situations when it would be helpful. It was almost zero. Very important new finding, which I want to point out, is the shielding of the fetus during imaging methods using ionizing imaging. And till now, actually, it was always recommended to use the shielding, but there are solid new data which show that this is actually worsening the situation for the fetus because of the scattered ionizing from the X-rays. So therefore, it is nowadays not recommended at all. Regarding anesthesia and analgesia, there has been a nice improvement in last years, because we have more and more data about surgeries which have been performed during pregnancy. So also for anesthesiologists, this is quite a common situation. It is clear that if possible, we should use local regional anesthesia. For gynecological cancers, if we need to perform pelvic lymphadenectomy or procedure on cervix, it is sometimes quite difficult. Therefore, you need to use general anesthesia. Regarding the postoperative analgesia, which is very important, because we have data when we know that postoperative pain can cause an initiation of premature contractions. Therefore, adequate analgesia postoperatively is really important. Here, we prefer epidural analgesia. Also, one of our recommendations is acetaminophen, but we have heard recently from President of the United States that this is not the best choice. So maybe we'll need to update the guidelines. We'll see. Opioids, of course, not in a high volumes, but you can use them throughout almost all stages of pregnancy. For non-steroidal anti-inflammatory drugs, usually we prefer to use it only in the second trimester. Now, one of the most highly debated issues were, of course, in surgery. And most of the debates were regarding cervical cancer surgery. Here, we have performed an extensive literature search to collect all published cases on simple trachelectomy, on abdominal, vaginal, robotic or radical trachelectomy, and so on. And it was actually confirming our previous findings that simple trachelectomy is considered safe. Almost all patients who underwent this surgery delivered at term, except of one patient, while abdominal radical trachelectomy, and there are around 40 to 50 case reports, were almost always associated with a high morbidity and also high mortality of the fetus. Therefore, it is not recommended to be performed during pregnancy. Interesting data we are collecting throughout the years about lymph node staging, and it is again confirming that you can perform pelvic lymphadenectomy, but from the technical point of view, we should limit it till 25th week of pregnancy, as beyond this week or 24th week of pregnancy, the oncological safety goes down. It means you can harvest less and less lymph nodes. Even though there are some centers who performed pelvic lymphadenectomy even in 32nd week of pregnancy, but in a common sense, this should not be done above 24th week of pregnancy. Very interesting issue is sentinel lymph node mapping, because you know that in cervical cancer especially, and also in vulvar cancer, it is a very important issue, which is the beginning of our staging procedures. There are some reports on the use of indocyanine green, and they are quite positive, but due to a low number of these cases, there were actually 2 published, and we have performed with 3 patients. So let's say very few patients have been treated with this. So we cannot recommend it routinely, but this should be one of the things which you should try within like a clinical trial or a protocol, prospective protocol. Regarding the technetium for cervical cancer, it is not recommended. For vulvar cancer, there was one report which used it, but again, we cannot really say that this is a good choice. Regarding patent blue, we know it's contraindicated because of the risk of anaphylactic reaction. Medical oncology, it's a huge field of our treatment and of our guidelines. What we would like to emphasize is that before every cycle of chemotherapy, the patient should be consulted not only by medical oncologists, but also by obstetrician. It is very common that this is not done, and it can lead to a premature delivery because some of the patients have some obstetrical problems which could be missed. And if you give chemotherapy to a patient who starts delivering within 2 or 3 days, then you end up with a large problem with the neonate. The mode of delivery is also an interesting issue because in the past it has been thought that if you have a cancer in pregnancy, you need to have a cesarean delivery, but this is not true. Of course, it is recommended for invasive cervical cancer, but especially for ovarian cancer or tubo-ovarian malignancies, it is recommended to perform delivery by spontaneous delivery. We have also spent a lot of time creating flowcharts in order to help everybody to understand how to guide the patients. Here for cervical cancer, we have divided it below 24th week of pregnancy and above 24th week of pregnancy. The cutoff is due to the pelvic lymphadenectomy, seen here. Then we have performed also, or we have created a flowchart for vulvar cancer, which was not that difficult. It was really quite straightforward. We are really proud about our flowchart for adnexal masses, because this is always a problem that everybody tells us or give us guidelines based on the stage of the disease. But for adnexal tumors, you always have to keep in mind that when you go for the surgery, when you actually plan it, you never know what stage this patient is. So therefore, we have started to create the guidelines based on the apparent early stage or apparent advanced stage, and then we went through the next follow-up. So this was about the introduction about the guidelines. When you download the guidelines, they are quite straightforward and easy to read, just really fast statements. If you want to have more information, then you can actually download the supplementary file, which includes about 65 pages of huge solid text, which is explaining almost every statement or all statements which we have in the guidelines, including large tables and also including the reviews of literature and all the case reports. So if you are interested in this topic, I recommend you to download it also, because then you can have a deeper insight. But I can imagine that you don't want to read these 65 pages today, so I'm happy to answer your questions to help you a little bit with the reading.
Excellent. Well, Michael, thank you so much for that excellent presentation on the topic of Tylenol and pregnancy. I'll have you know that we did invite the President of the United States to join the Journal Club, but we're still awaiting to hear from his team. So as we move forward, then we'll just go through our questions. But yes, thank you so much. Let's start with Matilde.
Thank you, Professor, for your presentation. What was the main point of discussion among the experts during the development of the guidelines?
Actually, we had quite a large concordance of our first draft with the reviewers. But actually, most of the discussions were about actually ultrasonography in pregnancy. It was really interesting because there were several groups who were pointing out that a lot of adnexal masses should be examined by expert ultrasonographers. And there was a discussion about whether during every pregnancy you should look at adnexal masses and on the ovaries. That was a really big issue. But actually, most of the discussion was about surgery, and especially about this abdominal radical trachelectomy and simple radical trachelectomy, because clearly there are a lot of centers which are using radical abdominal or vaginal trachelectomy, even though nowadays, fortunately, we have a very nice paper from the SHAPE trial, which actually gives us a lot of strength to state that in small tumors we can obey the parametrectomy. This means to obey the radical trachelectomy and to use simple trachelectomy. So actually this was really helpful in most of the discussions. So these two topics were mainly actually those who were debated.
Excellent. Thank you so much for that. And I think on a related topic, Masha from University Hospital in Munster, Germany, Masha Pervin.
Hi, thank you so much for this wonderful presentation. In which cases of FIGO 1B1 cervical carcinoma is it acceptable to perform a simple trachelectomy or a large conization during pregnancy?
So this is when we look at our flowchart, we can have a look, for instance, here. So actually for 1B1 tumors, we would divide it based on the gestational age of the diagnosis. So if the patient is below 24th week of pregnancy, we should start with a pelvic lymphadenectomy. In all cases, we prefer minimally invasive approach. We have a lot of data on laparoscopic approach, but actually nowadays there are more and more reports on robotic approach, which is also quite interesting, and especially in skilled centers, this is quite an interesting topic, because using robotic approach, you can use lower intra-abdominal pressure. and this can be helpful for the surgery. So in these cases, based on our guideline, we recommend simple trachelectomy in case of negative pelvic lymph nodes. That's what you can see in the bottom here. If you would have a patient who is above 24th week of pregnancy, it means you are not eligible, or you should not, or you are not able to perform pelvic lymphadenectomy upfront. Therefore, we feel that performing just a surgery on the cervix is not oncologically safe, and we cannot justify it. So there are several options, but what we have found quite often in the published literature is that in these cases, most of the centers start with neoadjuvant chemotherapy. We know that neoadjuvant chemotherapy in cervical cancer is quite a controversial topic. We are happy that there are nowadays more and more publications looking at the use of neoadjuvant chemotherapy. And actually, historically, in pregnant patients, this was actually one of the experimental choices which has always been debated. So just to summarize my answer, below 24th week of pregnancy, we would feel safe to perform sentinel simple trachelectomy in 1B1 tumors with negative pelvic lymph nodes.
Excellent. Thank you, Mike, for that answer. And now we'll turn it over to Joni Nouveau in Newfoundland.
Hi. So my question for you, and now keeping in mind that I understand that the guidelines, it takes several years, months to get ready. But this is about Keynote A18. So if a patient with locally advanced cervical cancer needs to start neoadjuvant chemo during pregnancy, would you consider to treat her with concomitant chemo rads and pembro after the delivery?
Advanced cervical cancer, we have several options, again, based on the gestational week. If we are close to the third trimester, we can consider using actually the induction chemotherapy like in interlace. So that's what you are actually pointing out, that you can give 6 cycles of weekly paclitaxel carboplatin. So, and actually this will postpone the delivery till higher gestational ages. I didn't point out in my presentation that the gestation week of the delivery is really determinal for the whole life of the newborn, because we have found out from already large case series that every week of prematurity means 2.5 degrees of IQ less. So if you perform delivery at 30th week of pregnancy, you start or you give the child the chance to have normal life quite low, because she starts with an IQ of 75. But it's not also, of course, always 100%. But so in advanced cervical cancer, we would go for induction neoadjuvant chemotherapy after that delivery, and then we continue with chemoradiotherapy. If you would like to know from me that I will use then the combination Keynote A18 combination with pembrolizumab, it is an interesting option. I have actually looked at the literature, and to my knowledge, there is just one paper from California, or one project, actually not paper, but it's a study, which is combining neoadjuvant chemotherapy with pembrolizumab and chemoradiotherapy with pembrolizumab. But till now, there are actually no data, but for sure, it's interesting. It is an interesting way how to move forward, but you need more information.
Thank you, Johnny, and thank you, Michael, for that. We have actually quite a number of attendees, about 50 attendees, and we're starting to get questions from the audience. And this one's from Albert Jacob, and he's asking, I was interested in the incidence of postpartum hemorrhage in mothers after chemotherapy and also neonatal infections due to concerns of cytopenias based on your experience. Would you recommend prophylactic administration of growth factors?
Excellent. So we always need to divide this topic into two. So one thing is hematotoxicity to the patient or to the mother. And actually, we have found that the hematotoxicity is very low. We are now also running a project which compares the hematotoxicity during pregnancy and after the delivery. And we can clearly see that there are less side effects regarding hematotoxicity, but also alopecia, also in terms of nausea during pregnancy. So we have seen very few anemia or leukopenia or thrombocytopenia during pregnancy. Therefore, we do not recommend to give routinely growth factors, even though actually they are not contraindicated. So in certain circumstances, for instance, in hematological malignancies, they are quite commonly used. But for gynecological cancers, for the regimes of chemotherapy which we use, which is paclitaxel, carboplatin, or cisplatin, or bleomycin, and so on, it is not that common. So it's quite rare. For the newborn, this is also, it's a very interesting question, because we know that some parts of chemotherapy will transfer the placenta to the newborn. And actually, our center has published already 2 papers where we followed prospectively the pregnancies. And we have an excellent tool how to evaluate hematotoxicity in the newborn using ultrasonographic exam of peak systolic velocity, which can very precisely tell you about the anemia of the fetus. And actually, it is true that it's certain chemotherapies, for instance, when we used ifosfamate or what was it, carboplatin, sometimes you can find anemia, even though in majority of cases they are not that severe. Even though, to be honest, and we have published it, we have 1 demise of a newborn, which we think it was due to anemia, but it was not very clear. So actually, hematotoxicity in fetus you can monitor by ultrasonography. And last point about the newborn hematotoxicity. We know that if there is a delivery which occurs within 1 or 2 weeks after last cycle of chemotherapy, then almost always you have a quite severe neutropenia and anemia in the newborn. It's because normally the kidneys and liver of the mother, when the fetus is in utero, will take care of the toxic agents of chemotherapy. But if there is a delivery too soon after last cycle, then the newborn's kidneys and livers are not ready to maintain, so they need a lot of support. But actually, all cases end up in a good way. I mean, nothing happened to these fetuses, but they end up in ICU and they have a difficult start in their life for sure.
Great. Thank you for that question, Albert, and certainly encourage others to place your questions in the chat as well. So we turn over now to Italy, Tommy Meschini.
Hi, thank you for this wonderful presentation. I want to ask you, in cases of advanced cervical cancers where a pregnancy preservic approach is not intended and radiotherapy is indicated with the fetus still in utero, either with or without prior feticide, how does this scenario influence radiation planning? Are there specific considerations regarding dose distribution, field, or expected toxicity due to the anatomical presence of the fetus?
Mm-hmm. This is a very good question, because we debate this topic from the first guidelines. And actually, there are very few data on this. But I would say that we can also divide this question into 2, because it is not that clear that you need to start chemoradiotherapy with fetus in utero, because I would say that 1/2 of radiotherapists and also gynecologists prefer to start with evacuation of the fetus. It means if you are in the second trimester, you can perform sectio minor. I mean, talking about cervical cancer, of course. So you can perform sectio minor to evacuate the uterus, and then you can start chemoradiotherapy, because both possibilities have pros and cons. If you start chemoradiotherapy with fetus in utero, and you can imagine that you have a 16th, 18th week pregnancy, large fetus, then we know that within approximately 30 days, there is a demise of the fetus. But then you have a risk of disseminated intravascular coagulopathy. You have a risk of large infection, inflammatory response. And actually, you need to replan your radiotherapy because of the uterus, which is getting smaller and smaller. So you are right that you need to consider this replanning. If you perform evacuation of the uterus in the beginning before the radiotherapy, you might end up with some small delay, because this takes some time. It takes the patient to recover for a few days. And also sometimes you can have some risks of infection. That was one of the major issues which we always heard about this topic. But on the other hand, when you look at the data showing that for cervical cancer, there is an acceptable delay of 6 to 10 weeks with the start of radiotherapy, you will never end up with a delay of 6 weeks. We are talking about the delay of 1 or 2 weeks. And actually, after that, you don't need any replanning, and you don't have a risk of disseminated intravascular coagulopathy, which can actually be very harmful to the patient. Not talking about the psychological point of view, just imagine that you are undergoing radiotherapy and it takes 30 days to the fetus to die. I would personally prefer the evacuation of the uterus first. That was always actually my thinking.
Yeah, really excellent questions from the fellows. Thank you so much for posing these questions for Michael. And next, we're going to go to Itzi Villagra in Spain.
Thank you so much for your presentation. I have another question. In the section of analgesia, the guideline mentions that best available options for pregnant women is continuous epidural analgesia. However, not all cancer centers provide epidural analgesia. Why epidural analgesia, and what substitution for centers without continuous analgesia do you recommend?
Thank you. I'm a little bit surprised that epidural analgesia is not available in all cancer centers. To my knowledge, it is quite a routine procedure. So, and I'm sure you are from La Paz. I'm sure that epidural in your hospital is common. So I think in majority of places, epidural is available. Why do we recommend epidural? It's because it delivers the analgesia like local regionally, so it will not influence the fetus. The other options which I have mentioned in the presentations are acetaminophen, also opioids, but most of these are still influencing the fetus potentially. Therefore, we feel that epidural analgesia is the best. Of course, for the procedure, you can also use spinal anesthesia, but this lasts only like for 10 hours after the procedure, so it's not long lasting. And I have to recommend or to repeat that the postoperative analgesia is really important issue if you want to prevent premature contractions. But I would say epidural is quite common.
Excellent. Next, we're going to turn over to Mo Byrne from Memorial Sloan Kettering in New York City.
Hi, thank you so much. This has been really, really insightful. I was wondering, so your guidelines suggest that minimally invasive approach is preferred over open surgery during pregnancy. And you touched on it a little bit that robotics give you the option for a lower intra-abdominal pressure. I was wondering if there's an ideal intra-abdominal pressure and gestational age and a suggested maximum time for surgery. And if you had any thoughts on specific port placements or optimal port placements during these surgeries. Thank you.
Thanks. Another excellent question. So first of all, why do we prefer a minimally invasive approach? The problem is that if you use classical abdominal incision, you have a large risk of wound healing problems. It is quite clear that when the uterus grows, it creates a pressure on a abdominal wall which has been incised, and this is quite a problem. Also, in terms of recovery, minimally invasive approach is preferable. And we have actually a lot of data also from non-gynecological procedures, from appendectomies, cholecystectomies during pregnancy, that we know that it is considered safe. Of course, minimally invasive approach is not for every surgeon. It's not that easy during pregnancy, like when you perform salpingectomy or TLH. It has to be really skilled surgeon, because the issue of a large uterus is quite important. It is really an obstacle during the surgery. So I have to add that minimally invasive approach, but in you have a nice child, but in experienced hands. Regarding the pressure, it's excellent, because this is always a matter of debate, and there were some trials trying to evaluate the capnoperitoneum and the influence on the patient, and most of the papers, but I would say it is not like a definitive recommend the procedure to last less than 90 minutes. But the data are not very solid for that. So generally it's 90 minutes, and the pressure we recommend as low as possible. We generally operate always at 10 millimeters, but for laparoscopy, you can sometimes go to 8 to 10. For robotic, you can go to 6. So that's clearly an advantage of robotic system. On the other hand, in robotics, of course, you don't have this haptic feedback. If you have the new Da Vinci system, then of course you can have it, but otherwise most of us they don't, and that can be a problem, because you should not, or you should avoid touching the uterus. If you are doing it by laparoscopy, you have the feedback, which is quite clear that you are pressing too much. With robotics, you don't have it. So again, it has to be really a skilled robotic surgeon. It's not for everybody.
Great. Well, thank you.
90 millimeters, not more.
Thank you.
Okay. Well, thank you. And thank you, Mo, for your great question and for inviting your baby to the Journal Club. Beautiful baby.
The youngest oncogynecologist.
I have to say, actually, I got an X-ray in pregnancy and they put lead on me. So now I know.
There you go.
Yeah, but to be honest, like 3 years ago, I was also prescribing it, and I did recommend it as well. But these are really new data. And also, it's not only for X-ray, but it also counts for irradiation during pregnancy, which is now actually more and more common, because we have, for instance, Hodgkin's tumors in mediastinum, or we have some tumors of brain or oral cavity, and we also used to use the lead apron, and nowadays it is contraindicated. But actually, it takes time to reach also the radiodiagnostics to know this, but you should be aware first.
It would be really interesting just to think about pregnant surgeons for surgeries using, like, orthopedics and things, because they wear lead for their surgeries. I don't know if it would have the same role.
Yeah, really excellent point. And perhaps actually also sharing these guidelines with our radiology colleagues as well. So now we'll turn over to Milano and Carlota Sabini.
Hi, thank you so much for your wonderful presentation. My question is, the guideline emphasizes pregnancy-preserving treatment when feasible, based on the evidence that pregnancy does not worsen oncological prognosis. Could you elaborate on how gestational immune modulation or hormonal changes might interact with tumor biology in this context?
So, I mean, the issue that pregnancy itself is not involving or it's not influencing the prognosis is very important. We have large data from registries. Most of them come from Scandinavia, which actually describe these patients. But we also nowadays have more and more matched control studies, which are more, I would say, more precise and more relevant to this issue. Until now, almost all of them are reassuring, to say this. But I'm sure that this will last for another 10 years to be really 100% sure. I think that we can always learn from breast cancer, because we know that especially breast cancer is a disease which is under a large hormone control, and there is a large influence of estrogens and progesterone. And even in breast cancer, it has been confirmed that pregnancy itself is not worsening the prognosis, which is really interesting. If you go to cervical cancer, vulvar cancer, we don't think that hormonal changes, there is no logic. Of course, we need to elaborate on this and recheck, but I don't think that it is an issue. For breast cancer, it has always been an issue, and even here it seems that there is no impact. The problem is that if you have seen some breast cancers diagnosed during pregnancy, almost all the time they are higher stages. This year we had 4 patients, and 3 out of them had already involved lymph nodes, large tumors, even involved liver, and it's because of a delayed diagnosis. It's not because the disease is growing faster. No, it's because most of the symptoms are mimicked by the pregnancy itself. And also, to be not nice to us and to our colleagues, some of our colleagues, they just say, no, it's not possible. Don't worry, it's nothing. It will disappear after the pregnancy. And actually, it's not true, because we have a lot of patients that actually it's one of the most common cancers diagnosed during pregnancy, because the average age of women at pregnancy is steadily increasing, and that's the reason why you can have this overlap with pregnancy and cancer.
Great. So now we'll pass it on to Paula Mateo, who is right here with us at Houston Methodist.
Hi, thank you very much for your clear presentation of the guidelines. I would like to ask you about tumor marker interpretation during pregnancy, as this can be particularly challenging due to physiological changes that affect marker levels. So, how should clinicians approach the use and interpretation of tumor markers such as CA25, alpha-fetoprotein, and human chorionic gonadotropin in the diagnosis and monitoring of gynecological cancers during pregnancy?
Thank you. It's quite easy to answer. Don't use it. They are useless. And there is a very nice paper which has been published again by our group or from INSIP. The author was Sileni Han, and she published already maybe 10 years ago a very nice review and overview what happens with tumor markers during pregnancy. And actually, especially CA125 and SCC, both of them, and CA15-3, they are all elevated during pregnancy. CA125 can reach 200, 300, 400 units. So it is useless to use it. For HCG, I mean, this is a classical parameter which we measure for normal pregnancy, and you are aware that it is always elevated. So basically, to answer, don't use it. It will not help you for the interpretation. You need to rely on imaging, especially for adnexomasis, you need to have a skilled ultrasonographist, which is number one for interpretation, because we know that especially adnexal tumors, they are very common during pregnancy, and most of them disappear during the first trimester. So you should not like panic and do anything. Just in majority of cases, ask for a skilled ultrasonographer. Some countries have certificates for expert ultrasonography for oncogynecology. We have this, for instance, in our country. It is quite common that every oncogynecological center has such expert. And then another issue is that you should wait till 12th week of pregnancy. After that, you should decide whether to go for active management or not. And we know that in young patients, such as these pregnant women usually are, there is a higher chance of non-epithelial tumors. And there are two very nice studies. They have both of them around 100 cases, and they show that for non-epithelial tumors, there was quite a high risk of hemorrhage or rupture of the tumor, or even death during the pregnancy. Therefore, in majority of our guidelines, we always say that if you have a suspicion on non-epithelial tumors, you should go to be active, to perform surgery. You can do it with pregnancy preserving intention, but take out.
Excellent. So, Michael, we have about just 5 minutes left. So we have two more questions for you. And that first one, it will be Saniru Marin Martinez from Mexico.
Hello, thank you. Thank you for your amazing presentation. And my question is, how do the difference in global healthcare infrastructure, including access to specialized centers and multidisciplinary teams, of course, influence the implementation of best practice guidelines for cancer in pregnancy, and what strategies could reduce disparities in care worldwide?
Actually, as I have said in the beginning, it is let's say, a rare tumor, very rare tumor. In our country, for instance, we see 30 patients per year, and that's it. 30 patients, so it's not a lot, and therefore this really calls for a centralization. So actually, always we try to recommend these patients should be centralized, and there should be always a dedicated team which deals with it, and that's number one. Number two is this is quite a fancy topic. To be honest, if we approach media, if we approach newspaper or television or Instagram, whatever, then this is always quite interesting topic. So I would say we have a lot of space in media, because it's involving patient and the newborn. It's always really interesting topic. So what you have to do is go out of your hospital, go to the newspaper, go to the TV, and try to talk about it. And then, of course, we try to influence our healthcare givers to understand that you need some kind of centralization, but everywhere this takes a long period of time. On the other hand, you have very solid data nowadays. Just imagine 20 years ago, there were almost no data about chemotherapy during pregnancy, instead of large, actually, series from Mexico, from hematological malignancies. So they were like one of the largest in the world. Otherwise, there were very few data, and now you have a lot of solid data, prospective studies, so you can more talk to the insurance companies or healthcare providers.
Excellent. And for our last question, we'll go to Matteo Lovero from Policlinico Gemelli.
Yes, thank you very much. My question is, this guideline recommends the systematic registry of all cases of cancer during pregnancy in databases like INSIP. And how important is this for shaping future practice? And more importantly, what are some barriers that you see to achieving comprehensive global registries?
Thanks. Well, of course, I'm a little bit ambassador of INSIP group, to be honest. Therefore, we recommend to register in our database. If you would search around the world, there is no other such a large group that really works for so many years and provides so many publications. So if you have in your country your own registry, use your own registry. But the thing is that these tumors are rare, so they should be registered in something. For instance, for breast cancer surgery, there is a large registry in Germany where we cooperate with and so on. But basically, I would say that our register is working the best. The issue is that from time to time, somebody comes with an idea how to investigate certain situation or certain diagnosis. So that's then very easy to reach really nice numbers from different countries and to have some solid data. But it is true that we are experiencing more complications because of the GDPR. So there are some countries where they cannot actually transfer their data, even though, of course, they are all anonymized, but still they cannot transfer the data. So in some countries, it is really difficult. To my knowledge, it was a problem always with French centers who really, we collaborate with them a lot, but their restrictions are really, really difficult to go around or to solve, actually, even though it's not anonymized. So there are some obstacles, but I would say 80 or 90% of countries go well. I mean, you need to ask for ethical committee permission. It's anonymized. Then you have your special account and you can register. And actually, from Italy, we are working with many centers for many years. So it is feasible there.
Well, Michael, thank you so much for this really very, very informative hour. Really a fantastic discussion. I think we have all learned a great deal, and I certainly encourage those of you who have joined in the Journal Club to read the article and certainly again to pass it on to your colleagues and trainees, because I think it's an article of great value. I want to congratulate also all of the co-authors and the leadership of Fred Amont in this topic as well. He couldn't be here with us. He's I believe on vacation now. So we really appreciate you being with us as well. And I want to thank, as always, the fellows for submitting their questions, really fantastic questions. And it really opened up a great deal of discussion. I also want to, again, thank the IJGC and ESGO for their support of this Journal Club and invite everyone to join us for the October Journal Club, which will be our article titled Endometrial Carcinosarcoma Without Myoinvasion. So we look forward to having you all join us. And for now, thank you so much once again.
Okay, thank you to all for listening and have a nice time.